Good evening, everyone, and welcome to Saliva Sleuths. I'm Heather Kenney. I am an HIAOMT certified hygienist and an oral microbiome educator and the founder of Saliva Sleuths. So whether this is your first webinar with us or you're already a part of the community, maybe even from the beginning, super glad that you're here. At Saliva Sleuths, we believe that dentistry becomes more powerful when we stop asking, what is the disease? And start asking what's driving it. Our mission is to help clinicians discover, decode, and discuss the oral microbiome as we better understand the microbial patterns behind oral and systemic disease, and ultimately provide more personalized root cause care for our patients. We cover these oral systemic topics in live webinars like these tonight, open microbe nights where we explore research, products, and cases, and through CE and non-CE courses that are in the platform. Tonight's webinar is especially exciting because we're talking about one of my favorite topics, and honestly, one of the things that started me on the entire journey of the oral microbiome. Years ago, the first time I looked through a phase contrast microscope, everything changed for me. Seeing live bacteria in motion made me realize that there was an entire microbial world happening right in front of us that we just simply couldn't appreciate with our naked eye. It's completely shifted how I viewed oral disease, patient education, and how incredibly connected the mouth and the rest of the body can be. And it was the experience that led me down the rabbit hole of the oral microbiome science, salivary diagnostics, oral systemic health, and I've never looked back. So I'm super excited tonight. We're zooming in to success as we're exploring the oral systemic connection under microscope to discover how seeing the microbial world can change the conversations that we have with our patients. And I'm super thrilled to introduce our guest speaker, my friend who we met a year ago talking about this very topic at Under One Roof. And she is one of our own Saliva Sleuths, Kristen King. Kristen King, RDH, BS, has spent more than 31 years biofilm peeping, studying the oral microbiome, and helping patients understand the oral health is far more than just brushing and flossing. She is also an IOMT accredited biologic hygienist and also the founder of Dental Reveal, and one of the leading educators in phase contrast microscopy for dental professionals. Through Dental Reveal, Kristen has trained clinicians around the world to confidently incorporate phase contrast microscopy into their practices, not simply as a diagnostic tool, but also one of the most powerful patient education tools that she can use. Her passion is helping dental teams bring the visible to life when patients can actually see what's happening within their own oral biofilm. They understand, they become motivated, they become more trusting, and they complete the treatment that they are proposed. Originally from Oklahoma and now based in Bangkok, Thailand, it is early in the morning for Kristen, and she has practiced hygiene throughout the United States and internationally. So bringing this unique globe of perspective to biologic dentistry and prevention, we are educating tonight on the little critters that swim. So if you haven't checked out Kristen on her socials, please look at Instagram. Her handle is at Kristen King Dental Hygiene. And check her out on LinkedIn, Kristen King, Biologic RDH. Kristen, thank you so much for spending the evening or your morning with us at Saliva Sleuths community. And we're incredibly excited to learn from your experience and take a closer look, literally, at the microbial world that connects oral and systemic health. So everyone, please give a warm Saliva Sleuth welcome to Kristen King. Kristen, the microscope is yours.
Well, first of all, thank you so much for having me. I'm really excited, to have my morning coffee with you guys. So thank you. Thank you. Here we are zooming into success, the oral systemic connection under the microscope. Okay, there's me cleaning Buddy's teeth. Yes, due to his diet of like spaghetti, M&Ms, what was it, chocolate syrup, maple syrup, crunched up Pop-Tarts, everything that he put on there. Yes, Buddy did have a very dysbiotic oral biofilm due to his diet. Anyhow, so yes, HIAOMT, AOSH member. You kind of already said this, so we'll just move on to the next. So this is going to be our basic framework right here. This measure, motivate, and maximize. This is how we're going to use the microscope in the hygiene ops. So this method transforms the microscope from a diagnostic tool to a communication tool. So we're helping patients to see what's happening in their oral microbiome, understand why it matters, and feel motivated to take action. So when patients can visualize the disease in real time, treatment acceptance, behavior change, clinical efficiency, and patient outcomes all improve. So these are the three ways, right, that we're going to let the microscope help you drive patient compliance for superior outcomes and for the patient and the clinician. So measure, we're going to measure the patient's risk of oral and systemic disease. Motivate, we're going to motivate the patient to modify behaviors, complete treatment, if needed. There will also be healthy biofilms out there. We're going to maximize clinical time, patient outcomes, clinician happiness, and we're going to maximize monetization, which also leads to clinician happiness. All right. So when we say we're going to view something under the microscope, this is what we're talking about. So it's a whole kind of microscope setup, if you will. There's three main components. One is the actual microscope, and it needs to be a phase contrast microscope at 40 times magnification. You can go higher, but then you have to do oil and stain some things. So for what we need it to do, 40 times is perfect. Why does it need to be a phase contrast microscope? Because it has a specialized optical light designed to enhance the contrast of transparent, kind of colorless, unstained specimens. So before the phase contrast was invented, they had to stain the specimens, and that killed them. And that's not really what we want. So that's not optimal. So when the phase contrast came around, it was perfect for viewing live cells and organisms moving about. So it's great for viewing dynamics and real-time behavior. So we also need a camera. The second thing we need is the camera. This actually catches the live video and sends the video to a screen. So it can record, video for sure, but it can also do still shots, things like that. It uses USB, HDMI, Wi-Fi, even AirDrop to get it to the screen. So the screen. This is how your patients are actually going to see their oral biofilm. So the camera live streams it, if you will, to the screen so that the patients can view it. So there's no looking through eyepieces. It needs to be just kind of easily and clearly seen by the patient from the chair. This is for ease and time management. You know, it's not easy for every patient to get up and down. That takes time. And honestly, even for patients that don't have a problem, it just takes up too much time. So it's just best if they stay seated. It's ideal to be seamless and efficient. So the screen can be a monitor. It can be sitting on a counter. It can be mounted on a wall. It can be on a mobile cart. It can be an iPad. It can be a tablet. It can be a computer, desktop, laptop, whatever. Some microscopes even have the little screen mounted on top. That's great for smaller areas. Again, optimally, the patient should be able to see it from the chair. I even know a microscope that has a detachable iPad. That thing is pretty amazing. Okay, this is one of my favorite patients in this whole world, one of my favorite people, my mom with their fun glasses on. So I just had to show a picture of my sweet mom. So I feel like all of us here in this room, this virtual room, already understand that chronic disease does not start with symptoms. It starts with signals. So subtle shifts in the microbiome, inflammatory markers, immune responses all happen long before labs are flagged, diagnoses are made. So think of the microscope like the intraoral camera, except we're looking at oral biofilms. So how much treatment does the oral biofilm how much treatment does the intraoral camera put, on your schedule? So can you even, imagine working without one these days? No. So the same thing really goes for the microscope. Think of it that way. And today I want to show you how oral biofilms, when viewed live under phase contrast microscopy, can predict oral and systemic disease. Okay, so oral biofilms act as a significant biomarker for both oral and systemic disease. Um, we all know what microbiomes are, right? But the oral microbiome is the community of microorganisms such as bacteria, virus, fungi, and possibly even protozoa, aka parasites, um, living in the mouth. So with the microscope, we have the ability to see that at-risk situation before clinical signs of disease are evident. So when you check biofilms and you start to see changes and dysbiosis happen, you can intervene and get that biofilm back to healthy, hopefully before any damage is done. And this is, I mean, I feel like this is true prevention, right? We're seeing something really early on and we're switching it up. Again, oral microbiome is the second most diverse in the whole human body. I feel like we always know that, second only to the gut. 700 different species of bacteria in the oral microbiome, and then adding, right, the fungi, the parasites, the viruses that can be living in there. The mouth is estimated to have over 20 million microbes. So the gut is the most diverse, and it's estimated to have 100 trillion. So again, the oral microbiome is one of the most information dense microbial environments in the body, and it just so happens to be one of the ones that's the most accessible, and we work in it every day. Um, this group also is aware what is in the mouth does not stay in the mouth, right? It's shared throughout the entire body via saliva, blood, lymph, even nerve tissue. We know this, but it is important that we share it with our patients. And I feel like it's important that we say those words. It is transmittable via blah, blah, blah. And the microscope is perfect for this. It's a beautiful visual to pair with what you're saying, what you're telling your patient about the oral systemic connection. Um, and at the same time, showing them what's living in the mouth. So I always like to tell them, we're going to show you, what's backstroking through your biofilm. The microscope is a fantastic tool for starting oral systemic conversations. So I would even say that it's almost impossible not to talk about the oral systemic link if you're using a microscope. And then you're going to, let your patients know when you see infection or inflammation in the mouth that it can be spread throughout the body, increasing their risk of all the things that we all know, right? Alzheimer's, all the things that we know. You can say that out loud to your patients. And then, you want to tell them, hey, we want to make sure that the mouth is healthy so it's not ground zero for infection elsewhere in the body. It's It is really impactful when you look at the patient's health history and then you tie it in for them, right? So customize a bit of what you're seeing on that slide and what you're telling them and tailor it to that individual patient. So, for example, you could say, hey, I saw in your health history that your dad has a history of cardiovascular disease. We know infections in the mouth can increase your risk of cardiovascular disease. We want to make sure that there's no infection in the mouth spreading to the rest of your body to increase your risk. Another one, you might, if somebody's wanting to start a family, right? And then you see a high risk biofilm, you can again bring that up, how the oral health is connected to getting pregnant and keeping a healthy pregnancy. This is not to scare patients, right? It's just about open communication and education. So we need to give them all the information and all the tools necessary to prevent disease, not just in the mouth, but throughout the whole body. I I feel like in this group too, you're probably already used to treating patients that have had some genetic testing done and know what their risks are. If you do, they're probably, if they have had that done, they're probably already pretty, invested in their health and willing to be on board with doing whatever's necessary to keep the mouth healthy. I would even go so far as to say their standard of care is probably pretty high and they will be expecting some type of oral microbiome testing. Another thing that's important to share with our patients um, is that oral microbiomes are transmissible. So when you're talking about oral biofilms, I do feel like it's important to say this out loud. Again, it's all the things we know, but it's just stuff that you do want to say. So you might want to, tell your patient, hey, if your significant other isn't keeping their oral house in order, so to speak, you're at risk as well. So, and same goes for the patient, right? Like if your stuff is janky, you're gonna share it to, to your loved ones, and who really wants to know that? So if you have biofilms that are still not quite healthy, they're not quite there after the patient, doing all the things, you really do wanna look into significant others, family members, the loved one, the pets, things like that. These can be a really constant source of recontamination, and that oral microbiome being something that's always changing all the time, we do need to it's great to constantly check it. If you have something that can quickly and easily check it every time they're in, instant results, that's a great tool. All right. There are micro ecosystems in the mouth as well. So there's various different ones. There's supragingival surfaces, right? There's the subgingival surfaces. There's the buccal mucosa. That one doesn't tend to have a lot of microbes just because of the constant shedding, sloughing of the cells. Saliva, dorsum of the tongue, tonsillar crypt. So these different niches provide different conditions like oxygen, pH, nutrients, mechanical forces acting on the surface, saliva, fluid flow, things like that, that favor different types of microbes. So, for example, what lives on the dorsum of the tongue is going to be a little bit different of than what you'll find in the tonsillar crypts. That'll be a little bit different than what you're going to find below the gum line. All right, so for the purpose of assessing risk of periodontal disease, take your sample from below the gum line. That's where the really good things are growing. That's the things we want to see. So we all know what the biofilm is, but again, explain it to your patient in terms that they can understand. I always like to do something simple like generic definition of a biofilm is a collection of various different microorganisms growing on a surface. If it's in the mouth, it's oral biofilm. So you can keep it pretty simple. I also tell them, look, the goal is to set up a situation where beneficial bacteria thrive, pathogenic bacteria do not. When we do this right, we do not have disease in the mouth, be it a cavity, be it periodontal disease. And again, we're ensuring that the mouth is healthy, not ground zero for infection throughout the rest of the body. And of course, in a perfect world, so what we eat, what we drink, how we breathe, how we clean our mouths is going to be sufficient to sustain this healthy oral microbiome. A great way to introduce the microscope is to just tell patients, hey, I have a microscope now, and it's a great objective tool to see what's actually living in your mouth. And you just tell them, hey, I'm going to get a biofilm sample. You already told them what it was, AKA plaque from down below the gum line. And we're going to look at it together at the same time under the microscope and just see what's in there. And then you tell them, hey, I'm going to give you a tour of your biofilm. And then also, before I ever even click on the microscope, I like to tell them, no matter what is there, no matter what we find, do not panic. It can totally be reversed. So it can be transformed from a, diseased at-risk biofilm to a healthy and protective biofilm. I like to use the word protective because it reinforces that biofilms are not inherently bad, right? That's another good way to say it for your patients. So we should not be trying to get rid of biofilms. It's not even an option. I tell them you're a living, breathing human being. Bacteria and all the other things are going to be there. So we just want good bacteria, right, to outpopulate and be the dominant bacteria in the mouth, and they will keep that bad bacteria in check for us. I love to tell patients, you have the power. You can 100% control what lives in your mouth. So use your powers for good. Okay. What happens when a microscope crashes into a telescope? Anybody know? Heard this joke before? They kaleidoscope. Haha, I love, love, love a good dad joke. I feel like that was a nice little break for us. All right, prepping the patient before the appointment. So whoever reminds your patients of their appointment, if it's done electronically, text, email, if it's you, whatever the case may be, remind them that you're going to be taking a plaque sample to evaluate their oral microbiome. So don't, tell them, we don't want to brush, we don't want to floss, we don't want to use mouthwash, etc. right before the appointment. We don't want them to dispose of the evidence is basically what we're saying. So you want to see what's actually going on in their mouths, what's actually living there. So I tell them, look, if you don't brush at 10 a.m. on a regular day, do not brush at 10 a.m. on the day of your appointment. So also, if you have patients do pre-procedural rinses, don't do that either. Don't do anything before you collect that plaque sample, right? So also no probing, just because we don't want to disrupt the biofilm formation. So you can do all the other things. You can take vitals, x-rays, scans, review health history, anything you want to do, just don't mess up that biofilm just yet. All right, so workflow. When it's time to get that sample, it depends on your situation really of when you want to review it. You're always going to grab the sample, first, take it, When you want to review it is variable. So again, for example, in a perfect world, each hygiene op has its own microscope and you do your thing. This isn't always possible. I understand that. So if there are multiple hygienists in an office and they have the microscope on a cart and you move it around, you share one, normally you will go ahead and just take your sample first thing, seal it, and wait for that microscope to be able to come into your room. If you have your own in your room, you can just take it and go ahead and show it to them. Then the rest of the appointment, you're kind of, you're talking about you're continuing to talk about what you saw, you're explaining it to them, and then you move forward with like, what's our plan of action? To seal or not to seal, I was taught both ways are fine. The sealant is acrylic, so just be sure I tell people let it dry. If put that lens down on top of wet acrylic, you're going to get acrylic on your lens, and that's a pain. I get really nervous about working with expensive equipment. I mean, it's not crazy, but it can be removed, but let's just let it dry. Um, a good thing about sealing it is when you seal it, it preserves it for a lot longer. They will dry out, fairly quickly. So when you seal it, you're saving it for later to show. Well, I like to, if I find a really, really high risk biofilm, like a really good one, even if I didn't seal it and I get it on there and I'm showing it to the patient in my mind, I'm like, oh, this is a good one. I'm going to go ahead and save it. When I take it off, as I'm still talking, I just grab the sealer and go ahead and seal it and set it to the side. That way I have a slide to show patients who have a perfectly healthy oral microbiome. And then you're talking to them about, they're always curious, well, what would unhealthy look like? Then you can snap one in really quick just for education purposes. I also like to do that if I have a really healthy one, because patients that have a really high risk kind of go, well, what would healthy look like? And you can describe it. Obviously you will, but then it's nice to also maybe have one and go more like this. And I just would kind of keep them to the side. And then at the end of the day, you can dump them. And if they're really good, you can call your friends over also. Um, It also, when you seal it, keeps any air bubbles from moving because it does kind of lock things in. So it kind of slows down that flow a little bit if there was an air bubble. The fastest is honestly, though, to just show and go is really, you can do whatever you want for the sake of time. All right. What can we see with the microscope? Let's get to the good stuff here. So with the microscope, you assess the risk of disease by morphology, movement, and what's actually present in the mouth. So you're not really going to be able to determine the species of bacteria with the microscope. For that, you're going to need to send off to the lab for DNA testing. For example, can I go ahead and say, I think I can, right? I'm allowed to say, like with Heather, you can send it off with Bristle and talk to Heather about it. So that's when you need to know the exact species. So the microscope pairs beautifully with salivary testing. So if you have patients that have been reluctant to do salivary testing, the microscope is a great way to kind of nudge them in that direction. If you show them a high risk sample, you can say, wow, I'd really love to know the exact species. I'd really love to know exactly what's living in there. There are things you can see with the microscope that aren't commonly tested in salivary testing. So with the microscope, I would say we kind of go a little bit wider, and with salivary testing, you go deeper. What do I mean by that? So typically salivary testing, you get the species, you can get viral testing, you can get inflammatory, you can get so much stuff. Parasites, I feel like Heather and I have talked about this. Parasites are not typically checked in most salivary testing. There is a company that I know of that can test for some parasites, but that being said, I think they only test for amoebas, not trichomonas, and we'll kind of get into that here in a minute. All right, so what can you see? I already said this, right? Like a live video of what's living in your mouth. So it's really huge. It's so enlightening and educating for patients. They normally really lean in when you're showing them what's living in the mouth. So people are curious. It's fun. Make it fun. Right. So you can see white blood cells, red blood cells, bacteria, yeast, parasites, dinner from last night. I'm always really careful to make sure it doesn't sound like I'm coming from a place of judgment. So it's not about that. That is totally useless and doesn't do anything for anybody as far as I'm concerned. So we can be honest without judgment. Also, which patients you can joke with. I certainly have had some really fun patients where we both laugh at, the total dumpster fire that is their oral microbiome. But we still come from a place, remembering if you have control, we can fix it. So we're in it together, right? Like we're a team. I think that's one of the things that I really like the most about the microscope is you can use it as a tool for information, and then you and your patient, are a team with the goal to either get them back to health or continue on the path of health, if there's not a lot going on. So you're the team captain, you're in it together, you support them. I personally find this way more effective with patient motivation. Another thing that's important is not to take anything too personally, right? Like if they see this really high risk biofilm and they're not ready to move forward with treatment, pass the salt, you've educated them, you've planted the seed, you can kind of move on. Um, Anyhow, so that was a little bit ranty. So biofilm samples will be assessed for risk of disease, right? So healthy protective biofilm, if that's the case, you just have discussion on what the patient's doing and hey, it must be working. Whatever they're doing must be working kind of deal. Moderate risk for oral and systemic disease. This is great for intervention before damage, or too much damage is done kind of situation. High risk for oral systemic disease. Typically, when you have a high-risk biofilm present, you're already seeing clinical signs of disease. You're seeing bleeding, you're seeing inflammation, bone loss. Not 100% of the time, though. Every so often, you're going to find high risk, and you're going to go, how is there not more clinically going on? And then that's when you have to kind of step back and go, okay, immune system function, how long has this high-risk biofilm been there? So when you put that sample under the microscope and click it on, you give the patient, a tour of their biofilm then. So you literally show them what's there, what it's indicative of. And at this point, I feel like I always have to like rein myself in. You show them what's there, move on, keep it quick, just a minute or two, and then you start working and you can be explaining while you're working. White blood cells. Okay, remember with the microscope, we have the ability to see an at-risk situation before clinical signs of disease are present. A great example is white blood cells. So I know that there's a test, chairside test for white blood cells somewhere. I know that it exists. With the microscope, you can see them as well. So white blood cells are the first responders in the innate immune system. So in this case, it's the oral environment's chemical response to invaders. In the mouth, the most common type of white blood cell is the neutrophil. So when viewing with the phase contrast microscope at 40 times, you'll typically see that it has a nucleus with anywhere from 3 to 5 lobes. Those will be the bigger and darker that we can kind of see in this. And it will also have cytoplasm, which will look like little dancing dots inside of it on the video. We'll see in a minute. White blood cells can be present in small amounts, in a healthy situation. White blood cells migrate to the sulcus in large numbers if there's a microbial challenge. So if white blood cells are too numerous to count, it indicates an inflammatory response. It's already happening, and that is considered high risk. It tells us that there's an active immune response going on. This is important. So the idea is that we show and explain this to the patient, and then they can take action to reverse the situation, hopefully right before damage is done, and that's kind of prevention at its finest. Red blood cells. When gingival capillaries become leaky, red blood cells and white blood cells leak into the interstitial spaces and the sulcus. So with the microscope, you can see red blood cells in the biofilm when there's not even kind of visible bleeding present. They look round, kind of hollowed out, centered in the center of the disc. All right, so here we have, something in the middle being attacked by some spirochetes. We'll get to that. Here's some white blood cells, 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 white blood. So it's basically when you start looking a whole sea of white blood cells in various stages of death, if you will. But try to kind of see if I can find a good one. It will be right in here where you will see the cytoplasm and the dancing dots. And all these are just smushed in the video that we're looking in right now. Dead and dying white blood cells. I clicked the wrong button, so sorry. Smushed in dead and dying white blood cells at various, stages in their life. Let me get to the red blood cells. There was one in here somewhere. So you'll see some red blood cells coming up. They look a little bit darker, they're smaller, and they have there we go, right here. are some. So those are your red blood cells, just to give you a kind of a size comparison, if you will, how they look a little bit different. All right. I want to say, guess where I found this one. So I love to find microscopes all over the place. This one was in my dermatologist's office. So yes, they use microscopes in dermatology. And when of course, I had to ask her about it. And she was like, yeah, we do scrapings because certain skin, even with like acne, there's a fungal component they have found. So everybody's using a microscope. Dentistry can too. All right. So again, with the phase contrast microscope reviewing live bacterial movement, and it can be seen by the patient and the hygienist at the same time. So this is super motivating to patients. Again, like the intraoral camera, except it's for biofilm. Patients love it. You all know how effective the intraoral camera is. You can show the patient the video of their active oral disease. So there's no questioning, is that mine? They saw you take the sample. It's been in the room with you the whole time. You can explain bleeding, probe depths, bone loss, etc. Sometimes patients still just don't get it. They really don't understand how severe it is, and they need a visual. Right. I already mentioned this. The microscope, you assess the risk by morphology. So you determine just kind of the family by the shape, not the species. Again, you can send it off to get the exact DNA if you need that species. So again, it pairs beautifully with the salivary testing. I really like the two together. But for looking at the microscope, low population of bacteria with low risk pathogens is just that, low risk for disease sample. So you're going to mainly see rods and cocci in there. Moderate risk is going to have moderate amount of population of bacteria present, and then you're going to have certain moderate risk pathogens like spinning rods, clock arms, things like that. High risk biofilms are going to be really densely populated, a lot in the slide, it just almost looks like a frenetic activity going on. You're going to have high risk pathogens like spirochetes, white blood cells too numerous to count, possible parasites. For the sake of today, I'm really just going to focus on high risk because they're more fun and we got to keep it moving. Oh, well, okay. Also, I just said that, but here's a healthy biofilm sample. So you see the plaque, that's me focusing in and out. And then just kind of not a lot going on. This one was really not a lot going on. But this is healthy. So just so that you have a comparison, this is why I like to save some of those healthy biofilm samples to show patients for later also. And, I like to call them protective, like healthy and protective, because again, it reinforces that biofilms are not all bad and we do not need to try to kill everything. That is not the goal. It's possible that good bacteria will just help protect against the bad bacteria and disease. So the wording helps stress to your patients also that we need to just to nourish and encourage that good bacterial growth. All right, let's get. All right, spirochetes, high risk one. So this one is it's a highly pathogenic bacteria related to periodontal disease. It's very invasive. They're capable of breaking into and out of blood vessels. They can cross the blood-brain barrier. They're shaped like little corkscrews and can actually burrow into tissues. So they live subgingivally. They can be anywhere, but they really like it subgingivally. They damage the epithelial wall. Treponema is a genus of the spiral-shaped bacteria. There's over 75 different types of oral spirochetes that have been found in the mouth. If you're familiar with salivary testing and you see the high-risk pathogen Treponema denticola, that's a spirochete. So the tightly coiled, like thicker ones, they're normally more mature from a more mature and established biofilm. Thin, loosely coiled ones are normally younger and newer formed biofilms. 6 different types of oral spirochetes have been found in the brains of Alzheimer's patients. That's another great way to tie in the oral systemic link. So especially if the patient has done genetic testing and knows they're at an increased risk for Alzheimer's disease, you want to go ahead and let them know, hey, I want to make sure that we get rid of this and get this oral biofilm back to good and healthy so that we are not adding another risk factor for that. If your patient hasn't had salivary testing, but reported that they do have a family with Alzheimer's disease, you can still discuss, you don't know, maybe they have the genetic risk. It doesn't matter. But again, we want to make sure that we keep the mouth good and healthy and protective. All right, so here's a great video of spirochetes in action. They are pretty easy to see. They look and they move around like these little worms or little snakes, if you will. That alone, I feel like, makes patients really want them out of their mouths, right? So they immediately go, how am I going to get rid of them? They love to attack and eat things like white blood cells. So if you can imagine, they're really counterproductive to healing. So when you see spirochetes, you typically have a patient with bleeding. We've all seen patients that bleed, and then present still with not a lot of plaque, like light to very light plaque. Um, and I'm not talking about the ones that obviously did not brush their teeth for quite some time and then decided to go gangbusters right before their appointment. We all know what that looks like. That's not what I'm talking about. I'm talking about patients that you feel like they really are doing a good job day to day, and you're kind of scratching your head going, why are they bleeding so much? It could be what's living in there. So kind of not so much the quantity, but the quality of the biofilm. Of course, it can be other things, as well, so many things, but in this case, in many cases, I see this. So of course, when you see this slide, it really does make your patient, they're basically asking for treatment when they say, oh my gosh, how do I get these out of my mouth? That's your intro to, well, here's how you're going to do it. And just, I mean, looking at that makes you want to run for your toothbrush. So, all right, yeast. It's a commensal yet opportunistic. So, and seeing it is not an immediate cause for alarm. There's over 100 fungal species found in healthy biofilm. So just because it's there doesn't mean it's a problem. Remember, we have this diverse ecosystem in the mouth, so it can be present anywhere from 50 to 70% of the population. Candida albicans is responsible for, more than 80% of human candidiasis. So overgrowth equals problems, though. So if we're checking biofilm samples at every hygiene visit, we have the ability to see tiny shifts and hopefully catch any overgrowth before the patient starts to have clinical symptoms. So if there's an overgrowth, you just ask the patient, hey, what's changed? The majority of the time, it's something as simple as a round of antibiotics. And then also, don't forget, if you're showing the patient an overgrowth, like they can see it themselves. So they're like, oh yeah, there it is. If it's a regular patient that is used to seeing their oral biofilm and they know what it normally looks like, they can even point it out like, hey, that's different. What's going on there? So here, again, we have a patient that's engaged in their own health. This is huge. An engaged, motivated patient is going to move forward with treatment. They are, for me, those are the ones that I really enjoy working with, is like, oh my gosh, right? What are we going to do with this? How are we going to get this turned back? How are we going to turn this ship around? So, and then that's when you go in and you discuss how you address a yeast overgrowth in your practice. Um, another, what I think is really fun about having the microscope as well is it's really fun because you can check and see what's working, like what treatments are working for your patients. So I've seen patients get better just from starting oral probiotics. Have them come back in 6 weeks for another slide. The biofilm is back to normal with with oral probiotics. I mean, yes, they're doing all the things, but like with the oral probiotics, they're back. They're good to go. Now, if there's a yeast overgrowth in the mouth, there's likely a yeast overgrowth in the gut as well. You explain this to the patient. You can even ask them, hey, do you have a functional medicine doc, a nutritionist, naturopath, another healthcare provider that you work with? I'd love to let them know what we found here today and how we're treating it. You can send this doctor a referral letter that says something like, hey, Dr. So-and-so, I saw our mutual patient, Heather, today, and we found an overgrowth of yeast in her mouth, and then which we are treating. However, you tell them, I know if there's a yeast overgrowth in the mouth, there can easily be yeast overgrowth elsewhere. I'm referring them back to you for evaluation and further treatment, if you deem necessary. So this is a great way to start to network with other doctors. So they go, who is this person? What are they doing? You're showing that doc the great care that you give. And you guys already know this. There are functional medicine practices that are doing salivary testing right now. If they have high-risk oral pathogens, they are looking for someone to partner with. I always tell practices, let it be you. Right now in the US, there are 5 medical doctors to every 1 dentist. This is a great opportunity for dental practices. This can be an amazing source of exponential growth for a practice. So, using that microscope is a great way to just kind of reach out and work with other healthcare providers in your area. It's huge. We'll get to this a bit more in a minute. Here's an example, a good picture. It's a little bit odd, I think, the optics, just because I had to zoom in so much, but this is a great shot of a yeast hyphae, how it would look on a microscope. All right, parasites. Generic definition of a parasite is just an organism that lives in or on another species, their host, and benefits from it. So it's not a symbiotic relationship. It's one way the parasite benefits and the host suffers, either directly or indirectly. 2 kinds of parasites that we can find in the mouth are Entamoeba gingivalis and, well, they're AKA amoebas, and Trichomonas tenax, AKA trichomonads. So these are not present in healthy situations. They're normally found in more advanced stages of periodontal disease. So if you see them on a slide, it is high risk. We'll start with amoebas. Entamoeba gingivalis is a parasitic protozoa. Not, again, not normally found in healthy spaces. It is in more advanced periodontal disease. They are anaerobic. They live deep down below the gum line. One study discovered that epithelial cells have a really strong innate immune response to Entamoeba gingivalis. So cytokines TNF and IL-8 had a 430 and a 360-fold increase in expression, respectively, when they come in contact with these amoebas. It really increases epithelial permeability, so that's not great. Amoebas also attack and eat bacteria, human cells. That same study found that white blood cells actually have little effect against amoebas, and amoebas' main target was the white blood cells. I lost train of thought there. So favorite food of amoebas is white blood cells. Again, this is counterproductive to healing if all of our white blood cells are being eaten up. They move around by their pseudopod, and so they throw out their little pseudopod and slowly move in that direction, surround their food, so that kind of helps make them easier to see. Another recent in vivo study found that Entamoeba gingivalis was able to go into cyst-like formation when exposed to a combination of amoxicillin and metronidazole, which is the combination frequently used to treat periodontal disease. I feel like that's pretty huge. Like that's pretty big. So if you have a microbe living in your mouth that goes into cyst form when exposed to one of the more commonly prescribed treatments, it's problematic. It makes me think, could this be a piece of the puzzle of why we sometimes see perio patients that get better initially and then over time they slowly go back to the way they started? Lots of things that's nuanced, right? But I think it's a piece of the puzzle, and everyone kind of admits that more studies need to be done on that. Um, but again, when you find amoebas, this is another great opportunity to reach out to the patient's healthcare provider and let them know what you found, and do they think that the patient needs, follow-up treatment. Again, if you find parasites in the mouth, they can certainly be found elsewhere in the body. So here's some still shots of amoebas. So you can see the little pseudopods are the darker spots. That's the direction that they're going to go. They are full of whatever they eat. So if you find a really big, fat, juicy one, they've eaten a lot of things. Again, right here, same thing. We've got some amoebas in there right beside some white blood cells. A if I see a bed of white blood cells and I see spirochetes, I'm slowing down and I'm really looking carefully for amoebas. So when they're really, really small, sometimes it can be tricky if you're going really fast. So remember, the white blood cell is going to tend to be more circular, and they're going to have the lobes, and they're going to have the dancing dots inside. The amoebas are going to be possibly more full. They're not going to have the dancing dots, and they're not going to be perfectly round all the time. So here's some amoebas in action. Again, this one, I sped this up a lot, so you'll see that the bacteria is moving pretty fast, but I sped it up so that you can see the actual movement of a couple of amoeba in here. And again, they're full of what they've eaten. They've eaten white blood cells. And again, they were found in this bed of white blood cells, dying white blood cells. So yeah, they just move about and eat all the things. Ever so often you'll find what looks like a still live moving spirochete inside them as well. I've done that. I don't have it on this slide, but I've done that as well, which is always really interesting. And then you can see spirochetes also just attacking things there. All right. Another type of parasite that can be found in the mouth, Trichomonas tenax. So these, again, are usually found in advanced cases of perio. They are anaerobic. They live down deep in the base of perio pockets. They move about with flagellar action. They typically have like 5 flagella, 4 free in the front and kind of 1 in the back. They've also been found in other parts of the body as well. So they're not just in the mouth. They've been found in lungs, the bronchi, submaxillary glands, tonsils, lymph nodes. T10X can also cause urogenital infections. It's a close relative to T. vaginalis. T. vaginalis can also be found in the mouth. So this kind of supports how things, it doesn't say there everything can go everywhere. And on a microscope slide, to be honest, you're not going to be able to tell the difference. Vaginalis tend to be a little bit bigger, but it's so small, you would have to do DNA testing to find out which one it really is. So again, with chronic infections, we really need to discuss recontamination. Other places that they're found, not just in humans, they're found in cats, dogs, horses, chicken cloacas. They are everywhere. So if you know what a cloaca is, it's disgusting to think that that could also be in your mouth. If you don't know what cloaca is, look it up later. You're welcome for that little bit of fun. Okay, guess where I found this microscope? Yet another microscope.
Urology.
Gynecology. Yes, basically, you're so close. This is in the gynecologist's office. They are everywhere. Everybody's using microscopes. Funny side story. I had a patient for years that was a gynecologist, and we would look at her oral biofilm, and she would always be like, oh my gosh, if there was that much going on in the vagina, it would be crazy town. And I was like, really? Like, I don't, I'm like, well, what goes on in the vagina? She was like, it is not that busy. No. So it was really fun. I was like, okay, well, you're, good. We got it. We got it going on. We know how to get in shape. All right. All right. So here's some trichomonads in action. They kind of look like a little mouse. So you can see their flagella in the front. I feel like in this particular video, it's kind of hard to see the one in the back. But again, you're going to find them in high risk biofilms. So I feel like you're already finding them with spirochetes. You're finding them with a lot of inflammation, a lot of bleeding. There's a lot going on. And then when you're really lucky, you will see this. You will see not 1, but 2 oral parasites in the mouth. So here we have this large amoeba being ridden by a trichomonad. So I feel like this is just microscope slide gold right here. This one was definitely sealed and kept for a long time. It was really good. So the patient, we had, again, a great patient with a great personality. So we had a lot of fun with this one. Okay, practice growth. So you can use the microscope to help practice growth in a number of ways. One is by filling your schedule with patients that you already have. So your existing patients. This can happen in a couple of ways. Patients say yes to periodontal treatment and actually get on the schedule. So you'll start finding a lot of high risk biofilms that may not even need active periodontal therapy, but they still need to be seen more frequently than just twice a year. This also fills your schedule. The patients that completed perio will need to be seen more frequently as well. So now your schedule is really starting to get full. A side effect of a full schedule is a really great, robust short call list. So no more of those empty spots at 10 o'clock on Tuesday. This is when you start to think, is it time to add a new team member, right? Like what's going on? You can also fill your schedule with new patients. Patient referrals is one way. So patients are so happy with their experience, with their results, and how they healed that they tell friends and family, right? They tell them how your office does this cool thing where they show you your plaque on a microscope. And believe it or not, that is a thing. I've seen patients come into the office because they were specifically wanting to see their oral microbiome under the microscope. One was because somebody told them, and then one was they heard it somewhere and then just like Googled it up, found the doctor nearest them that did it. So collaborating with other healthcare providers. This is another way for new patients. And this one is truly exponential. It is huge. It is a little bit of a slower burn, but man, it can be great. Let's even go back to the patient that had the parasites. You can refer them to let's say their naturopathic doc, right? It's just a great way. You see a whole lot happening there. You reach out and tell them, this is what we found, again, with the letter. Not all dentists are doing this, so it's a great way to kind of form a relationship with those other healthcare providers, right? They're like, oh, you're doing something different. Another thing you can do too is, even if you're not sending them patients yet, I would encourage people to go ahead and reach out to other healthcare practitioners in their area. Maybe just reach out, introduce yourself, meet for coffee, but explain what you're doing, what you're looking for. And that's a great way for your patients to also, that are looking for, some great healthcare providers. You have this wonderful network that you're working with. All right, so a quickie review. It gets you engaged, active, connected patients, so that are saying yes to treatment. So you're going to fill your schedule with motivated patients that are ready to say yes, right? Not just my free cleaning, not just what my insurance covers patients. So with the microscope, you're going to get instant results, right? You don't have to ship it off, and you don't have to wait on labs. It's motivating. I think that to me is probably one of the most important factors, one of the biggest benefits, for a couple of reasons. Patients are just going to go ahead and move forward and complete treatment. At the end of the day, you can have all the fanciest equipment in the world, but if patients never move forward with treatment, what good is it? You need to have something that's moving them forward. So having a bunch of dusty equipment sitting there doesn't really keep the lights on. So it's motivating patients to actually move forward with treatment. That's in complete treatment. That's huge. And the second thing it does, it helps motivate them to change their behaviors. And if you can motivate them to change their lifestyle and habits to be a little bit healthier, that's pretty life-changing. Another thing, early detection. We already touched on this. So we have the ability to see the at-risk situation before clinical signs of disease are present. So it shows you what you can't see with the naked eye. And when we go back to, looking at our traditional methods, diagnosing periodontal disease with probe depth bleeding, bone loss, all the things, they really detect disease kind of after, or already in the middle of it. So seeing it ahead of time is pretty important. So that's the prevention part. If we want to detect something early enough, right? And then we can change that course. If the patient is heading in the disease of direction, we can intervene, correct, and set them on a different path to, the path to health. Customized treatment. Let's say the patient has very little buildup, plaque, calculus, but moderate bleeding. You check that biofilm. We kind of saw this. We talked about this. You check that biofilm and it's high risk. Okay, well, we're going to discuss various things to try. Maybe after you disrupt the biofilm, you can use lasers, ozone, whatever you feel is necessary that you have access to, right? So perhaps the patient is just using a manual brush once a day, eating a bunch of processed foods. You might also recommend an electric toothbrush, whole foods, water flosser, dental probiotics, see them again in 90 days. You're going to check the biofilm again. Biofilms can change. So treatment success. The microscope helps monitor that success. So what's working? Are you going to wait until there's more bone loss? Are you going to wait until there's a lot more bleeding to kind of tweak things? You can quickly and easily and inexpensively check the biofilm at every appointment. So we already discussed how those biofilms change. It's just important to do that, to monitor success. Again, fill in your schedule. We already talked about that, getting patients to say yes to treatment. Job satisfaction. Working with patients that want to get better is just more fun. I feel like I already said that. I love it. Seeing patients heal and get better is fulfilling. I mean, that's why we got into healthcare in the first place. I feel like that for me really fills my bucket, seeing people get better and just also getting paid your worth for what you love. So I feel like job satisfaction is another really important aspect. Okay, more cheesy dad jokes, right? Two bacteria walk into a bar and start pouring themselves pints. Bartender yells, "Customers aren't allowed behind the bar." The bacteria say, "We're not customers, we're staff." So go have fun with it. Go have fun in your career. Go have go have fun in everything you do.
Awesome. Fun story. I think amoebas can also come, not just trichomonads, from your animals.
Yes, yes,
Yeah, I
totally.
I remember having like a teenager when we were using slides and they had amoebas everywhere. And I was like, "What are you doing?" And then we kind of nailed it down. I felt like there's a little bit of a water component with the amoeba issue. Um, she had a cat that would play in her water glass with her paws, and she was drinking after with it. And I was like, yeah, don't do that. We should not be drinking water that you're washing your cat's paws in, that they stand in
No.
poop.
No. Don't you feel like cats? And I don't know if it's because they just can jump and be on things and get into things. I feel like it's like cats a lot more than anything else.
Yep. Yeah. So,
It's definitely cats. And just even like the whole, and it could have been anything, right? So if the family, let's say we all live together, right? We're all exposed to the cats. We're sharing food, eating after each other, all the things. I will never forget. This was really a moment that I was like, wow. At the time, so it was mom and dad I knew had very high risk biofilms, like full on periodontal disease biofilms. The kids come in, and I think the youngest was like 7 at the time. There was like a little bit of bleeding, not a lot though, not anything that would make you before it would not have,
yeah.
it's a little bit now I know even a little bit of bleeding is not good. We should have no bleeding, but they're kids. You're kind of like, what? I was like, I just want to see what's living in there. Right. And
Yeah.
of course, mom and dad are like, yeah, let's see what's in there. I'm not kidding you. Just like mom and dad's, it was a full on periodontal disease, super high risk biofilm. And they were like, wow, but they don't have, kind of the issues I have. And I was like, not yet.
Yeah.
Right. Again, with their healthy, robust immune system. But I was like, you're looking at it like they will if we don't turn the Queen Mary around, so to speak. Like we gotta turn it around. So even with little kids, like it's amazing to me.
Yeah.
It's so fun. And the parents are so appreciative. Like they love it. Like I have to really rein myself in and be like, okay, calm down. We can't, like you would just want to use the microscope the whole time, right? The point is to make it seamless and efficient and not add one more thing for a hygienist to do in that time that she's already got or he's already got.
And you can see like dysfunction even with the red blood cells, like rouletting, where the red blood cells get stacked and they're not separated. And um, I had a patient that it was just coagulated red blood cells that were like pulling against each other. And it was just, it was like coin stacked, rouletted red blood cells all through his. And he had just been putting on a statin drug because he was just admitted for heart issues. And I was like, you're like a walking heart attack right now. If I look at your cells, and like the red blood cells are like sticking severely to each other. So you want the red blood cells widespread like you had in that, but when they're all stacked up like that, there's dysfunction there. Yeah.
I wish I had a good video of that. If you ever come across one,
I
please share it
I
with me. I
have
just
it.
don't.
I can share it
Oh,
with you.
please share it with me if that'd be okay. I'll credit you. Heather gave this to me. I just don't have one in
Yeah.
my bank. I would love one.
Yeah. Yeah.
Isn't it crazy that there's so much? That's what I'm saying. Like the microscope goes wide. You can kind of see more things, but then to really dig deeper, that's when that salivary testing comes in.
For sure.
Right.
And
And also when you think about different niches, right? Like what you find in saliva is still going to be maybe perhaps a little bit different. Like you might not have as high of a parasitic situation going on free floating in the saliva as you do in the base of a really juicy periodontal pocket.
for sure. Okay. We can share it live right now, actually.
Woo! Oh, Snapple.
See how they're just rouletted throughout. They're just stacked like coins.
Yes.
And you can see them getting, I think I have another video of it too, where, see if I can, nope. I do have, oh, this one right here. This is the same patient. Look at them pulling
Right.
through the biofilm there. And you can see it, how they're all like collapsed and sticking. That's a clot right there,
If you're seeing a clot literally in your subgingival biofilm, like what do you think's happening in your arteries?
right?
How did he respond to that? What did he say? Do you
We
remember?
asked him to go back to his physician. And his physician, he wasn't concerned. Yeah, his physician wasn't worried about it. But when I looked up one of the side effects of statins, is some kinds is it, it's rouletting. Yeah.
Wow.
You can see like how they're all like misshapen and collapsed here. Look at that. That's just
Yeah.
crazy. That is dysfunction in itself right there. Bad biofilm too, by the way.
Right. Like there's a little something for everybody in that one.
All of the above right there. Yeah. So I had to share that since you wanted to see it. Yeah.
I do have one other question. I don't know
Yeah.
if I should just pop it in the chat because I am starting to look at microscopes. So it would be nice if you guys have some that you're like, stay away from this, or this is a really good company. Because I have reached out to one company already, and he gave me a packet of stuff, but it would just be nice for some information that I won't be able to get.
Kristen, I'll let you head that one up. I have experience with 2 microscopes. I have opinions on both, I guess.
Ooh. Okay, I have talked to various different people about them. My personal hands-on experience has really probably been the same too that you have, Heather. I feel like it's kind of pretty common in dentistry. It's either going to be the Zeiss or
Yeah.
it's going to be that Leica, right?
Yeah.
I think those are both great. Where I landed as far as talking to Steve Miller at Miller Microscopes, is that where you got your information? Just out of curiosity.
I was talking with oh, hold on, let me find his email. Bill
Um,
Landers
Okay, Bill Landers. Yep.
Yeah.
So or tech. Yep.
with
yeah, that's
Zeiss
who.
or whatever is what they carry.
Yes, that's who I got my first Zeiss.
Oh,
Well, the first 2 that we worked with from. So Bill is really nice. He's a great guy. I like him. He's a wealth of knowledge. I feel like you call him up and you can get information from him. So I do like him. Um, if you're gonna let me back it up. I would go middle of the road microscope is what I'm saying, because you just want something like the Toyota Camry, if you will. Like you just need to turn it on and it works every time and it does its job. And then that's it. You don't need too much microscope and you don't need the cheapest one, because sometimes I'm getting this information from Steve Miller at iMiller Microscopes. They actually build microscopes. I can share his contact information also if you want. But he was telling me what his experience with them has been is with the really lower budget ones are in a couple years, maybe you go to flip it on and like the bulb is out or some piece doesn't work. And it's just a pain in the keister. I think that's the kind of stuff that drives me bonkers. So it's like, why not pay 2 or 3,000 more, get the one that's going to last you forever that you don't have any problems with. That's kind of where I land. That other really nice one, that's 10K. It is the cat's meow. I call it the sexy beast, but it's just more microscope than a dental office needs, to be honest with you. So it's like, but I like one thing you can do too, if you want a Zeiss right now, I can pass this information to you as well. Zeiss does online ordering. You get 20% off if you online order. Heather, I think maybe I sent this to you too as well. I don't know, maybe I didn't in the past, but Benjamin Figueroa, I can give you all this information if you want, but if you can talk to him. I have another practice that I worked with. They did not go with the Zeiss. It they went with Zeiss, but it wasn't the Axio lab. It was one a little bit lower in cost, and they loved it. And they get online, they talk to Benjamin. This is exactly what we need, X, Y, and Z. I can give you the here's what I need kind of deal. He can hook you up with it, tell you exactly what to order. Here's where you order online, clink, 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 pay, and it gets sent to you. And I feel like that was like the 5 or 6 range, maybe even, I'm going to say 5 or 6. And then if it's less, yay. But it's a Zeiss, but not the Axio lab. So just a less expensive one. I don't know. I feel like back in the day, many, 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 many moons ago, when we bought our Axio labs, they were from Bill. They were like 10 or 12. Does that, I don't know what he's charging now, but I feel
Yeah.
like that's what we paid.
They weren't cheap. I don't remember exactly which one we had. The Zeiss from ours. We ended up purchasing another monitor and connecting it to the monitor. I loved the image on the Zeiss. So I always kept mine at 40x. I barely had to move my tray. I knew exactly where and I literally barely touched anything. It was just a matter of moving it very slightly in either direction. So once I had it dialed in, I literally just, it was so easy just to I would move my lens out, put it back in and slide it in. I was almost in view. And I didn't really have to do a lot of adjustments. And it was close up. And I always looked at some of like the videos from some other individuals who are huge in the space, like Susan Relison and some of the other people in the oral micro or in the microscope space. And I was like, it's really far back. And then we went to HIAOMT last year. In the one that he had, I felt like we were sitting way back. And I kept being like, I just want to get close like the Zeiss. But we could have, but the picture wasn't as great, I didn't feel like, as the Zeiss had. So there's a little bit of differences there. However, the one that we had through Steve Miller, I loved that you could record directly onto the microscope and have your own saved downloaded videos to your patient chart. Was freaking awesome. So I would almost take a little bit wider lens to be able to have that camera image, because I literally used to stand with my camera and try to not have a shadow and that sort of thing. So the quality of what you could put in a patient chart instead of just staging or grading, like when you're grading your microscope slides, you'd have like mobility, grade A or B or C, right? Is that how you kind of teach, Kristen? You're grading your slide?
I don't even get that much into it
Okay.
sometimes. I'm like, do high risk due to this,
Yeah.
medium risk, low risk. I know
Right.
some people do like 0, 1, 2, 3,
Yeah.
4, 5.
So
I wish there was a way to make that universal too, by the way.
universal,
Just like
yeah.
yeah. Be like,
But
let's all get on the same page.
having a little clip that you could put in the patient chart would be sweet. And as someone who really likes to put case studies together, really excellent for that too.
And patients love it. Didn't you find that? They're like, can I take a video of that? Which is why I like the idea of the one that does airdrop. You just airdrop
Yeah,
it to their Apple phone.
and you have a real time of like, instead of like, oh, this is what we had written down for the last one. You actually have a video from one to the other in the patient chart from start to finish, rather than just like a description, which is awesome. Because you can still have spirochetes there, but how many were grade B spirochetes last time compared to this grade B? Right?
Well, and are they tightly coiled? They're super old, or maybe they look like they're new little babies. I mean, if
Right.
you really wanted to like get into the weeds of it.
Yeah. Yeah. So I would check out Steve Miller.
Yeah, I think he's a wealth of knowledge. Again, though, people have been really happy with that Benjamin Figueroa and the online.
Yeah.
Just ordering one online. I wish this is something that I'm working on, have tried to like manifest on. I want one link. I want to, again, with making it more universal like this, I would love to have a microscope custom built exactly the way I want, just exactly what we need, like just the 40 times. Like I know Steve likes the 10 and the 40. Like you don't even need the 100. I don't think you need the 10. You didn't use the 10, did you, Heather? You just used the 40?
40.
And Steve really didn't understand. Like he would keep talking, because I've had so many phone conversations with him. He is delightful. But he would be like, no, and the 10 is for this. I was like, Steve, you're talking about dental people. Like, they don't even ever teach them anything else. Just go to the 40. We've got a million other things to do. If you teach them, I did it just like you did, Heather. Just move the lens out of the way, put it on the light. There's where it is. You can see it. Click it on. Let's go. It's right there.
Yeah.
Yeah,
I
it's
like the
you-
40x view. It's lovely. I think at IOMT we had 100. Were we at 100x? It was like way out.
What were we at? It wasn't 100 because I know at 100 you have to start using oil immersion and staining.
Oh yeah, I don't know.
Like
It was
100 is
I
too
felt
much.
like it was too far out.
Maybe it was 10.
Maybe.
Maybe, right? Like maybe we still had it on the 10. Honestly, I wish I could remember that. I've had too many sleeps since then.
You're right. I think we had it on 10. And I remember, yes, because 10 would be further out. We had it on 10. And I was like,
Yeah.
how come I can't see real in? So, but yeah, so that was, yeah, I would not use 10, 40 all the way.
Don't even buy. That was the other deal. Like I taught, and I have had a couple conversations with the Zeiss people too, with Benjamin in specific, and asked them, can you make this for me? Don't even put eyepieces on it. Don't even just get what's a 10 for this, no eyepieces. And he was so kind. He was like, let me look into it. He hits me back and he was like, honestly, for us to pull them off the line and get them without the eyepieces and do this, he goes, you'd have to buy, he's like 500 units or whatever. And I was like, well, I don't know that I'm in the position to buy 500 units and hope that I sell them right now, maybe later, but it's not happening for me right now, Ben. So he was like, your best bet is to just go, continue to go forward. So somebody needs to build a specific to the dental op, hygiene op. And I mean, let it be me. If you guys know any hookups, please send them my way.
Awesome. Are you teaching at all in the US ever?
That's still my main people. I get people it's mainly US, and I'm not for sure if I just pop up on their radar. I feel like a lot of Europeans, a few hit me up. Some of them are doing it. I get a lot from New Zealand and Australia. I don't know how I'm popping up on their radar, but I am.
Australia has a huge following because Susan Rollison is in that area.
Okay.
There's two really big speakers on the subject in Australia, so that's why you're getting those.
Well, she must be doing a good job because a lot of them are already doing it or already know about it and have been thinking about it for a while.
Yeah, I know. So perfect. All right. Well,
Love it.
we'll stay in contact.
Okay. Melissa, how shall I get a hold of you to send you any contact information? Like, do you want me to do it through Saliva Sleuths? Do you want me to, you want to send me, I'm Kristen at Dental Reveal, if you want to email me.
It doesn't
And I can give you,
whatever's easiest for you. If I don't know if you want to put it in the Saliva Sleuth so other people can benefit from it, or I don't know, whatever.
Love that.
I like that.
Sleuth Lounge.
Okay, let me make a note. The Sleuth Lounge for Melissa. Okay.
That
AKA
is awesome. Thank you so much. I was just on their website and there's just so many microscopes. I'm like, I don't even know what I'm looking at. Like,
right. Don't you wish there was one button? This is the one you can use. Here, click. Like that's
it's
my
just
goal.
so overwhelming.
Yeah.
Because I'm like, I don't know. Do I need the best? Because I don't know. And then you guys are like, no, just get the middle of the road. I'm like, I don't even know what one is that. Because there's like, 20 of them to choose from. I don't know.
I'm with you. What I did too is got with Benjamin and he said, here's exactly what you need. Go here, click this. And he told me and click there's that. But there's still some different ones. But yeah, I would love to narrow it down to one, to be honest with you, and stop. To me, I found that's the friction point for people. It's that confusion. And then I don't know what, it's a pretty decent investment. So
And then I
yeah.
would have never thought of the camera piece. Like you can record it and just drop it in. That sounds way easier than taking pictures to compare.
I would spend a little extra money to be able to have those video cameras. Like the video.
Yeah, it's like trying to explain and describe a oral lesion versus let me just put the probe beside it and take a bunch of pictures and you can compare and contrast. next time way easier than
Right.
2 millimeters by 2.5, you know? So
Totally.
Yep.
And it needs to be easy, right? And efficient, or we're not going to use it in the hygiene app.
It's the IO image of a pocket.
yes.
I love that. Let me write that down. Can I go ahead and post that and credit you?
Yeah, for sure.
So many pearls out of this.
Perfect. All right, my friends, we'll wrap. Thank you.
Thank you guys. Well done. Great job, Kristen.
Yeah, thank you.
Awesome. Awesome. Thank you guys.
Really wanted people to get something out of it. I was really nervous. I was like, oh, I want to make sure they get something out of this.
Yeah, you nailed it.
Mission accomplished. Yes.
Well done. Well done. All right.